Good afternoon, everyone. My name is Lynette Corona. I am the Healthcare Program Specialist at CDPH's Healthcare Associated Infections HAI program. I will be your host for today's webinar. Today's webinar is entitled Candida auris in Orange County and will feature presenters from the Orange County Healthcare Agency as well as the Centers for Disease Control and Prevention. We will wait until the end of the presentations to address any questions to the presenters. Please type your questions by using either the chat or Q&A panels, and we'll make sure to get them answered accordingly. You can access these panels by hovering your mouse over the bottom center of your monitor screen, and several icons will appear. Click on either the chat or Q&A icons to open the panels, and then type in your questions or comments to be addressed by the presenters. Thank you, and I will now turn the presentation over to Dr. Aaron Epson, Assistant Chief and Medical Director of the HAI program at CDPH.
Great, thank you so much, Lynette. And thank you to all of our participants for joining us and also for your interest in learning more about addressing this very important topic. As we'll hear from our presenters, the auris presents a formidable infection control and public health challenge, and so we at CDPH and the HAI program greatly appreciate the tremendous amount of work and diligence of our colleagues at the Orange County Healthcare Agency and also the assistance from CDC in our efforts to contain this pathogen in California. So thank you, everyone, for participating in this webinar today. And with that, I will turn over the webinar presentation to Dr. Matt Zahn with Orange County Healthcare Agency.
Great. Thank you, Aaron. Can everybody hear me?
Yes, you sound fine.
All right. Great. Thanks, Lynette. Thank you, Aaron. And thank you all for taking the time to listen into the webinar from your busy days. And also thank you to the CDC for attending this webinar and providing assistance with it as well. I'm going to start by talking about the epidemiology, what we've seen in Orange County thus far, and then my CDC colleagues will follow up with a description, not just about a bit about what we've seen here, but also more generally the experience and the recommendations that the CDC has for responding to Candida auris in general. So our initial case where a situation was identified was a young man who was previously healthy, has a history of Down syndrome, but was admitted to a local hospital, 29-year-old resident from our county, was admitted to a local hospital from mid-December of 2018 until mid-January of 2019. Initially had back surgery, but then developed medical complication, including pulmonary embolism and significant illness. After a prolonged hospitalization, he was transferred to long-term acute care hospital A in Orange County on January 15th and has been there since that time. One note here, so we have sent out multiple advisories and we've talked to multiple other persons I think who are on this call, infection preventionists and others, about the specific long-term acute care facility. We are past the point where we're naming individual facilities because multiple are involved. So in fairness to this facility, we're calling it LTAC A. The clinical status of this patient at the point where the patient was at LTAC A was a significant cerebral disease, was ventilator dependent. He had a tracheostomy, a PEG tube, and a Foley catheter was placed long term. A urine culture that was obtained from this catheter was positive for Candida auris. And this is really the event that started us down this pathway of investigating. I would note that this is the first case of Candida auris in Southern California and the second case ever identified in the state. In Northern California, there was one case. I would also note that this case had no obvious travel history, and so that led us to begin an investigation to identify exactly the spread of the scope of Candida in Orange County, Candida auris. our CDC speakers will speak far more in depth to this, but just as background here. So this is Candida auris is an organism that was first identified in Japan in 2009. Since then, rather rapid international spread has occurred, though again, in many parts of the United States, including California, it's remained rare. It can act like other candidal organisms, cause a variety of different type of clinical illnesses. What is quite distinct about Candida auris is that it shows resistance to all three, or can show resistance to all three commonly used antifungal classes, echinocandins, fluconazole, and amphotericin, which was really, that resistance is what makes us concerned from a public health standpoint. Long-term care hospital A is, excuse me, was someone speaking? Okay, I'm sorry. Long-term care hospital A is one of three LTACs in Orange County with 42 residents in a 4-bed ICU. None of the residents there were identified to have foreign travel either. And a bit, broader for LTAC. So when we had initially identified this case, we had talked with the CDC, and we've been talking with the CDC virtually every day since that time. And it's important to recognize that LTACs as facilities are at particular risk for seeing outbreaks of Candida auris. This has been seen in around this country when Candida auris cases have been identified and clusters have been identified. They have strongly tracked with LTAC facilities. In low likelihood, this has relates to the fact that Candida auris is particularly prevalent both to cause colonization and disease in severely ill patient populations, and long-term healthcare facility stays wherein there's multiple antibiotic treatments also probably facilitate this fact. Now, how do we identify this? It's terribly important to recognize that LTAC's laboratory did us a tremendous public health assistance based on encouragement from public health. Because we knew LTACs were at particular risk, the LTAC's laboratory has been encouraged and began speciating its Candida isolates to see whether they were identifying Candida auris or other species. That started happening in September 2018, and that process was really what identified this organism. I would note, when many facilities say we've never seen Candida auris, if your lab does not speciate, then it's a bit hard to know that you're actually going to identify it. I would also note that because it's important that speciation is necessary in order to identify cases, we have reached out to facilities, acute care hospitals that frequently share patients with LTAC-A, so that to assure that those facilities are speciating their Candida clinical specimens. We are not recommending that at this point for all hospitals, acute care hospitals. We also, we're only recommending it at this point for facilities that, again, share patients consistently with this facility. Now, in addition to in terms of initial follow-up to identify whether there's a larger issue, we conducted a point prevalence survey with LTAC-A. This means that we went to every patient who was a resident of LTAC-A and swabbed them to see if they identified cases. At that first screening, we did identify multiple additional patients who screened positive for C. auris. As a practical matter, or in general, we are continuing point prevalence surveys every 2 weeks at this facility to assess and identify an additional spread of cases. Once we identified that multiple patients were found at that facility, we then began to work with the facility to assure that there was an organized patient transfer and potential identification of any other patients who may be colonized after they leave LTAC-A. I will note that we have sent out multiple provider advisories about this situation, and I'll give you my contact information later on in the presentation. but I would note we are sending advisories and trying to keep people aware of what is going on. So if you are not being kept up to date and haven't seen these advisories, please let us know, and we can add you to our list. Now, in terms of infection control precautions for patients who are admitted to acute care hospitals or SNFs, so if they have suspected or confirmed C. auris colonization, then the following steps should be taken. For patients who are admitted from B SNFs or LTACs who are confirmed, or if they're suspect to be Candida auris positive, standard and contact precautions should be consistently adhered to. Emphasize adherence to hand hygiene. Alcohol-based hand sanitizer or soap and water for hand washing are both acceptable as a practical matter. Most of the time, alcohol-based hand sanitizer is much more easily made broadly available in facilities, and so that tends to be the best way to go to make sure that your hands are clean before and after you're seeing patients. Whenever practical, placing the patient in the single patient room. When we have talked to facilities who have identified cases, and I'll talk a bit more about our additional facilities in a minute, it's also really important to realize the environmental components of potential spread for Candida auris, and so we have emphasized the importance of using the appropriate recommended products, List K from the EPA. Those type products are appropriate. And then finally, inter-facility communication regarding Candida auris. So if a patient is suspected to be colonized, and that means the patient has just been transferred from a facility with known cases of C. auris, that patient should be screened when they get to the new facility. As I noted, there are point prevalence screenings that are going on in these facilities every 2 weeks right now. But if a patient was swabbed 5 days ago and then gets transferred today, when the patient arrives at the new facility, the patient should be placed in contact precautions, and the patient should have screening performed at that time. To give us just an overall sense of what we've seen for patients who have been transferred from facilities with known cases. So we've had patients who've gone to skilled nursing facilities, to acute care hospitals, and to home. Of these, we have had a large number who have been swabbed and they have been tested. We have had only one positive person who left and went to a skilled nursing facility. So this is testing that's happened after they have left the facility. So there are a large number of people who have been tested. We've had very few positives, but we are still waiting on results for many people who have been transferred. As a practical matter, if a patient goes from a facility that is suspected to have or has known Candida auris, if they go to the next facility, they will be tested, and they may end up in contact precautions through their stay, waiting results. If patients have been discharged home from facilities with confirmed Candida auris in that facility, once discharged to home, the general experience from the CDC is these patients seem to be at very low risk of remaining colonized, getting healthier, even getting out of the subacute side of the skilled nursing facility to the regular skilled nursing facility side. Getting healthier seems to coincide with people becoming a lot less likely to be colonized. So when they go home, in general terms, unless there's an unusual situation of someone with significant illness at home, no precautions are recommended. So if they go home from LTAC A, they can go home, and there are particular precautions to take. We did send a letter to all patients who have been discharged home from LTAC A when this situation was identified, to make sure they understood the situation and to offer testing for those patients. I must tell you, most of them did not take us up on the offer of testing, but we sent them a letter and said, if you access healthcare, take this letter so the healthcare providers understand what is going on. If these patients who have gone home return to a facility, you certainly may choose to test those patients when they come to the facility. Again, our experience has been that these patients, once you get home, there's something about getting healthier that makes you much less likely to remain colonized, but you may elect to place them in contact precautions and retest when they come back to your facility. So going back to that one person who screened positive and went to when they were at a regular skilled nursing facility, not a subacute care, but a regular skilled nursing facility, just to get the sense of what we did. We placed the patient in contact precautions. They did have a roommate. We screened that roommate who turned negative, who was found to be negative. We didn't do a point prevalence survey in skilled nursing facilities. We have not done them in acute care hospitals. The experience on a national level has been those point prevalence surveys really are most useful in subacute parts of skilled nursing facilities and LTACs. For acute care hospitals, if you have a habit of, if you are a facility that shares patients with LTAC-A consistently, we have reached out to your facility and told you that you ought to be speciating Candida isolates. Again, we are not recommending this speciation for every facility in the county at this point. We have not done point prevalence surveys in acute care hospitals. You can guess we've identified facilities where some of these patients who are colonized have been, but point prevalence surveys in acute care hospitals have not identified cases, so that's not something we're pursuing with acute care hospitals. Now, so VSNFs, so skilled nursing facilities that provide ventilator care for patients, is another group in addition to long-term acute care hospitals that have been found on a national level to frequently harbor patients who are colonized with Candida auris. There are 14 such facilities care for adults in Orange County that provide this service. We identified 3 facilities that most frequently share patients with long-term acute care hospitals. Of note, in these VSNFs, typically one side is the subacute side with ventilated and most seriously ill patients, and the other side is the regular skilled nursing facility. We have had point prevalence surveys done in these VSNFs on the subacute side patients. So it is strictly that patient population that seems to be at highest risk, and that's where we've been screening. And so on to the next slide. A note about point prevalence screening. If you look at the CDC website, the CDC recommends screening of axilla and groin. To doing PCR or culture testing, you can do. Chlorhexidine use, chlorhexidine bathing conceivably makes swabbing less sensitive. Adding the nary swab for those patients makes sense. Because we have many facilities in Orange County that are using chlorhexidine for bathing their patients on a regular basis, we have routinely recommended for our county that all patients, when you're looking to screen for Candida auris, you screen axilla, groin, and nares. For testing results, you can either get culture done or PCR. PCR is nice because the results come back more quickly. I would note that only public health laboratories, a select number around the country, can do testing for screening purposes for Candida auris. We have a couple of labs that are helping us. The CDC lab across the country is doing PCR testing for isolates for these facilities that have had identified cases. And so if you are a facility that has a single patient come to you from an LTAC or a VSNF that has patients, that culture will be the method to be done. It takes a bit longer, but again, that is the logistics we have. We're trying to really use the PCR testing for those facilities that really need point prevalence surveys and results back quickly. So those 3 VSNFs that we did point prevalence surveys all had multiple patients who were identified who were colonized with Candida auris. So we have the initial LTAC, and we have VSNFs that are affiliated with that LTAC that have all had patients who screened positive for Candida auris. Based on that experience, we talked with the CDC, and the CDC has provided additional resources here in Orange County. CDC staff are here right now trying to get all the rest of those 14 LTACs and the other all the rest of those 14 VSNFs and the other 2 LTACs patients screened with point prevalence surveys. I would emphasize that, the natural question is, where did this start? We don't know where it started. We know that multiple facilities at this point have colonized patients, and we are trying to identify in the high-risk facilities, VSNFs and LTACs in Orange County, what the scope of spread is. I would note that we are broadening our reach to be screening multiple facilities that have had no positive cases at all. So if you receive a patient from a VSNF or an LTAC in the county that may be undergoing screening point prevalence survey but haven't had any positives yet, for those patients, we are not recommending that those patients need to be screened and put in contact isolation when they go to the next facility. Obviously, the goal here is to assess and minimize spread of Candida auris in Orange County. We terribly appreciate all of the help the CDC staff have made to doing this. You may get a call from your facility from CDC staff. Just know they're here in Orange County. They're in our office trying to help us out. I think you also may be aware that, for better or worse, this has become a significant media question over the last few weeks, partly at least due to a New York Times article. We are working hard to answer questions that come up in the media. Our goal is not to raise more agitation and concern that is necessary. We're really trying to reach out to facilities whose patients are at highest risk. This is my contact number for my office. I will turn it over to Dr. Balabinini from CDC at this point. I will tell you we're going to have question and answer at the end. We probably will have more questions than we have time to answer. You can certainly take down my contact information and send the questions on to me. Dr. Balabinini and her staff have been talking to us virtually every single day, and so they have been a huge help. And if you send questions to me, that will be effectively sending questions on to them as well. So thank you all for your time, and Snigdha, I ask for you to present at this point.
All right. Good afternoon, everyone. Can you hear me?
Yes, you sound great.
Okay, thank you. So thank you again from CDC for taking time to listen to this webinar and learn more about Candida auris in Orange County. There's you all are in a position, really, you're going to be the ones seeing these patients, and you are in a position to make a difference in the trajectory of this in your county. And we're hoping to provide you with a little bit of information on this today so that you can take action to, prevent or at least limit the spread of this organism as much as possible. I'm going to give a little background on Candida auris and why we're so concerned about it, why we have a CDC team in the field helping out with the efforts that the county is really leading. And then I'm going to hand it off to my colleague, Kara Jacobs-Slivka. Dr. Slivka is an infectious disease physician and really an expert in infection control issues in long-term care settings. And since that's the place that we're really going to probably see auris, we wanted to focus a little bit of the talk on that. So when I'm going to start off with a little background on Candida auris. When you think of yeast, I don't know what most people think of, but before I started to do this work, I thought of bread and yeast, things you're familiar with, things you may be using in your day-to-day life. And then if you have some clinical background, you may think of yeast as something that caused diaper rash. Vaginal yeast infections are something people are really familiar with. Thrush in babies' mouths, or some patients who have some cancer or HIV. These are common infections caused by the yeast Candida. But Candida can also cause very serious infections that involve the bloodstream, heart valves, and then even meningitis or brain infections in little newborn babies. And Candida is actually one of the most common cause of healthcare-associated bloodstream infections. There are hundreds of species of Candida. There's about 5 really that mainly cause infections in humans. But today we're going to talk about one specific species called Candida auris. And the reason we're concerned about Candida auris, there's 3 main things that I really want to make sure everyone on this call today understands. One is that Candida auris tends to be drug resistant. It's not all hopeless. It's not that all isolates are highly drug resistant, but it's a lot more resistant than any other Candida species we know of. And that's what is concerning. And on top of that, on top of the resistance, it can cause severe infections. So it can cause these bloodstream infections, and I'm going to talk about that a little bit later. It can cause many other types of infections, but the bloodstream are the ones that we're really concerned about. And then, you have this very drug-resistant bug that can cause severe infections that can spread easily in healthcare settings. So it's not just affecting one patient, but many patients can be affected. And with the combination of these three things is what makes C. auris concerning. Next slide. Okay, so the first thing I wanted to talk a little bit more about is antifungal resistance. So there are not a lot of different types of antifungal drugs available. There's only 3 main classes of antifungals. And one of the problems with Candida auris is that more than 90% of isolates around the world, and we've tested a few thousand isolates at this point, they are resistant to one of the main drugs that people use to treat fungal infections, and that's fluconazole. So more than 90% are resistant to that. And then 35%, about a third, are resistant to polyenes, which is like amphotericin B, and that's a very toxic drug, so generally not preferred to be used, but it's even resistant to that drug. And then echinocandins, which are really, the one drug that IDSA recommends for treatment of invasive Candida infections. We're seeing that about 3% are resistant to that so far in the U.S., and many of these isolates are resistant to more than one of these drugs. And in the last couple of months, CDC has also confirmed that we have 2 isolates in the U.S. that are, or 2 cases in the U.S. that have had pan resistance, meaning they're resistant to all 3 of these classes. And thankfully that's rare, but what we're worried about is that that becomes more common and then these infections will be untreatable. The good news about this is that we don't think this pan resistance was transmitted from patient to patient, but it was acquired. The patients had been treated with a number of antifungals and then over time acquired resistance to all of the medications. And that is something that concerns us at CDC, that we don't have a lot of antifungal classes of drugs available, but this bug is becoming resistant to these drugs. So that's one issue, is the antifungal resistance. And then the next issue, as I said, is that it can cause severe infections and death. So there's many types of clinical specimens for Candida auris. It can be found in blood, urine, sputum, wounds, and finding these infections has been a challenge because most clinical laboratories only tell you the species of Candida if it occurs in blood, and generally, if it's seen in urine or sputum, even wounds, it's considered a colonizer, and most people don't actually determine the species of this. Most laboratories don't. And so it's easy to miss a case of this if you're not doing that. And so we have specific recommendations, and actually one of the reasons we're doing this webinar today is because the Orange County LTACs have really stepped up and done the urine speciation to try to find cases as early as possible. But I'm going to focus a little bit on the bloodstream infections because they are they are a common invasive infection caused by Candida auris. Of the 600 or so clinical cases we have in the U.S. to date, half have been bloodstream infections, and 45% of people with bloodstream infections die within 30 days. And not all these deaths may be directly related to Candida auris. That's important to understand, but it's happening in very sick patients, and sometimes this can just put them over the edge and cause death. And although a lot of these, people are picking up these colonization with Candida auris in long-term care and nursing homes, a lot of these bloodstream infections are detected in hospitals because people get sick and then they get transferred to the hospital with a bloodstream infection and they get diagnosed with it in the hospital. Next slide. It typically affects the sickest of the sick. Dr. Zahn covered this, and this is really important. We've learned a lot about the epidemiology, about who this affects, and what we found is that it does not affect the average patient, and definitely not a healthy person who's, let's say, a healthcare worker who's well enough to come into work these are not the people who are going to be affected by Candida auris. It's really patients who've had extensive healthcare exposure. They've been in hospitals, nursing homes, in and out of these places, and that's who ends up getting sick with Candida auris. A majority of these patients have tracheostomies. They're ventilator dependent. They're often colonized with another multi-drug resistant organism like MRSA or carbapenem-resistant Enterobacteriaceae. Sometimes they even have had C. diff co-colonization or co-infection. So we really see it in patients who already have some of these other bugs you may be more familiar with. And then a key feature is also we've seen that many of these patients have recently received specifically antibiotics, and some have also received antifungals. And these are the types of things that, the patient would need to have in order to, be susceptible to Candida auris. Patients can be colonized for a long time. So colonization really means that they carry it on their body, but they don't show any signs of illness from it. So it's not like C. diff where you can smell the diarrhea when someone has C. diff infection. This is C. auris colonization, where they just carry it on their body and you don't see it. The main sites of colonization are skin, and that's really, we detected in the axilla and groin, that's armpit and groin, and that's because Candida auris really likes warm, sweaty, and salty environments, and so armpit and groin tend to be the places it likes to hang out, although we found it in other parts of the body, including the nose, the nares, and that's why in Orange County we're actually looking at people's nares also to look to see if they're colonized with C. auris. And it's important to know that caregiving staff, whether it's a nurse or a CNA doctor who's seeing these patients, are generally not going to be at risk for becoming colonized with Candida auris, and neither are family members who are there to visit patients. But it is important to know they're not going to be colonized, for the long term, but they can carry it on their hands, and that's why Dr. Jacob-Slifka is going to talk a lot more about hand washing and hand hygiene and the importance of that, because we can contribute to spread, even though healthy people wouldn't get sick from this kind of thing. And why is colonization important? Colonized residents can serve, or patients or residents can serve as a source of spread of C. auris to others. So it's important to detect, to know who's colonized, and that's what a lot of the efforts that CDC, California, State Department of Health, and as well as Orange County, that's what we've been working on over the last few weeks in Orange County, is to find out who's colonized, who's not. And then those who are colonized, not only are they at risk for passing it on to others, they're also at risk for invasive infection. So 5 to 10% of those who are colonized will develop a bloodstream infection within a year, and often it's occurring in people who have a procedure or devices or have been hospitalized. And then, as Dr. Zahn pointed out, we test for C. auris colonization by swabbing the armpit and groin as well as the nose, and then this testing right now is not commercially available, but we conduct the testing at CDC and some public health labs. And then the other thing that makes C. auris really hard to control is that it not only does it colonize the patient's skin and the patient stay colonized for quite a while, it also persists in the environment. So it can survive in a hospital room or a nursing home room for months. I shouldn't say months, for over a month. We've seen it can survive in the environment, and then commonly used disinfectants don't really work against Candida auris. So you really need the sporicidal disinfectant, something that's active against C. diff is what we say. And when that's used properly, you can remove C. diff from the environment. We've done studies where, we'll find it before a cleaning has been done, and then very thorough cleaning, and then we'll test the room again, and there's no sign of C. auris. So it's not that it can't be gotten rid of, but if there's no good cleaning or disinfection, that's when it tends to persist in the environment. And we've also found it not just in surfaces in the patient's room, but on mobile medical equipment. And this has become a big problem for transmission of the organism, because you see these things like blood pressure cuffs, if they're rolled around from patient room to patient room, that just takes Candida auris from one place to another. And then in terms of transmission, we've been talking a lot about, how it spreads from patient to patient. This is a slide that, shared with us from the Chicago Health Department. They've seen, quite a big outbreak of Candida auris in Chicago. And one of their skilled nursing facilities, a subacute floor that we're calling a VSNF, initially in March 2017, they had 1 out of 69 patients who was colonized with Candida auris, as you can see by this dark purple spot on the slide. And then about 8 months later, they did another point prevalence survey, and almost half of their patients had become colonized with Candida auris. And this doesn't have to be the case. This is, before we knew a lot about this organism, and now we know many things we can do to help prevent this transmission. But this type of thing has happened in long-term care facilities, and that's why a lot of our talk today is focused on this. It doesn't mean that it can't happen at all in acute care hospitals, but because the patients are there for a shorter time, we often don't see the transmission. It doesn't mean it can't happen, and certainly acute care hospitals also need to be concerned and looking out for this organism and making sure transmission isn't happening. These ventilated skilled nursing facilities or subacute floors of a nursing home are disproportionately affected compared to other types of long-term care facilities and skilled nursing facilities. And in a study done in New York City, they found that the prevalence of Candida auris colonization was 7.7% in skilled nursing in ventilated skilled nursing facilities compared to 0.7% in skilled nursing facilities. So again, really underlining this fact that Dr. Zahn talked about is that's why the focus of this intervention is really in these subacute floors of these facilities, because that's where we think patients are going to be at highest risk for Candida auris. So C. auris clinical cases have been reported in the U.S. As I said, about 600 clinical cases as of the end of February, and another 1,600, a total of 1,600 patients who are, that includes clinical and screening cases. And by screening cases, I mean those patients we find by swabbing the axilla and groin and finding that they're asymptomatically colonized with Candida auris. And so you can see here it's really grown a lot. We started tracking this in mid-2016 or so. We did find some cases when we looked back in some of these facilities, but it's really, the numbers have grown, the number of states have grown. The blue is New York, green is New Jersey, and orange is Illinois, and that's definitely where most of the cases have been occurring, but there's 12 states in the U.S. To date with cases, and we're trying to look for cases in other places early on. And this is a map of the states where cases have occurred. Again, Illinois, New York, and New Jersey are colored in very dark because they have had the most cases of any place in the U.S. But they're, as pointed out for California, this is the case in Orange County is the second known case of Candida auris, and I think what the difference is that if we intervene now, if everyone can work together to help prevent transmission, I think we don't have to be colored as dark as we are in Illinois and New York and New Jersey, and this is the time to really take action and, do what we can to limit the transmission. So just, again, to say that Candida auris in Orange County was found really because of this enhanced testing of urine isolates from the LTACs, as Dr. Zahn said. This is a unique, way that we've found these cases, because Candida found in urine is usually tossed out since that's considered colonization, but it's important to know if it's Candida auris because it has infection control implications. There's different things you would take, even if you're not treating the patient, different steps you would take to deal with that. It's now affecting multiple facilities, and our efforts there really, the goal is to find cases and prevent spread as much as we can. So really, the message here is that it's a new bug. It definitely sounds scary, but what we know is that it's using old tricks, and this is going to be to our advantage. We know that it's a drug-resistant bug. It makes people sick, and it spreads. And that's actually very similar to what we've seen with carbapenem-resistant Enterobacter ACA, CRE, with vancomycin-resistant Enterobacter ACA, VRE, MRSA, and other drug-resistant bugs that you all are probably familiar with. So it's new, but it's not, in fact, that different from all of these other bugs. And we know, we're learning a lot about C. auris, but we know how to control the spread of some of these other germs. And that's, you know, and we're using some of those same principles to help control the spread of Candida auris. And with that, I'm going to hand it over to Dr. Jacob Slipka, who is going to talk about the infection control measures that may primarily focus on long-term care facilities, but really applicable across the board to control the spread of Candida auris. Kara?
Thank you. And can someone just let me know that you can hear me all right?
I'm fine.
Wonderful. Perfect. Thank you. So I also want to continue to emphasize that the facility level prevention strategies that we're going to discuss a bit while we're focusing on Candida auris, these really are applicable to all multi-drug resistant organisms as well as other infections. And as Dr. Valvanini had said, these apply to all healthcare settings, even though I am going to focus on some of the unique challenges that are seen in nursing homes. And then strengthening these practices can help prevent the transmission of infectious pathogens and help to keep residents safe. So alcohol-based hand rub really is preferred over soap and water, except when hands are visibly soiled. And the reason that we say this is that we know that alcohol-based hand rub is more effective than soap and water at killing those bad germs on your hands. We also know that they can be more accessible than sinks and water and paper towel and soap, and that when we use alcohol-based hand rub, it's less drying and irritating on the hands than soap and water can be. I know that the question always comes up specific to C. diff, C. difficile, because we do talk about specifically using soap and water when there's an outbreak of C. diff or norovirus. So I will mention that. So when using alcohol-based hand rub, you want to make sure you get enough product on your hand and then rub your hands together, covering all the surfaces. Really want to keep rubbing until that product dries on your hands, making sure that you're getting in between your fingers, getting around your nails, getting on both sides of your hands and your thumbs. And it typically takes about 20 seconds. But since you're not stuck there in front of a sink, you can be doing this as you're walking down the hall or walking to the next resident or patient that you're taking care of. If you do end up using soap and water, you also want to make sure you're wetting your hands, applying that product, and again, rubbing all surfaces of your hands, focusing on your nails, your thumbs, in between your fingers for at least 15 seconds. Rinse, and then there should be paper towel, some type of disposable towel that is right there available at the sink in order to dry your hands and turn off the faucet. And just a reminder that hot water does contribute to drying of your hands, so ideally avoiding very hot water is a good idea. Hand hygiene should be performed before and after every resident or patient contact, and this includes any time before you put on any kind of PPE or personal protective equipment like gloves or gowns, and then it also includes performing that hygiene after you take off that personal protective equipment. Using gloves is not a substitute for performing hand hygiene. Your hands can still become contaminated either through a tear or a hole in the glove or in the process of removing those gloves. And the picture that I show is simply to remind you that it's not just contact directly with that patient or resident themselves, with their skin, with their body fluids. It's also contact with anything in that immediate, any item or equipment or even furniture in that immediate area. So in order to perform appropriate hand hygiene, it's really essential to be able to access it. And so providing immediate access to alcohol-based hand rub at every point of care is one of the ways in which you can maximize the use of alcohol-based hand rub and increase that adherence to hand hygiene. So this means things like outside of resident rooms, and ideally inside of resident rooms as well, especially when multiple residents occupy the same room, as hand hygiene should be performed after providing care for one resident and before providing care for another resident. Other areas where you can increase your access to alcohol-based hand rub include common areas, any areas where staff are working or passing through, therapy rooms, PT, OT, any kind of recreational therapy, and you may find additional locations as you walk through your own facilities. It's also important to have a plan in place for restocking those supplies, because if the supplies do run out, then again, having a dispenser there becomes less helpful. Create a culture of safety where staff are empowered to remind and encourage others to perform hand hygiene for resident safety. So providing training, performing auditing, and giving feedback are a way to do this. One example that I've included on here is something called Caught Red-Handed, and there's a link at the bottom of this slide to some information through APIC about quite a few different programs, but I've included pictures of Caught Red-Handed specifically because this is one that has been popular and is actually kind of a fun way to do some training specific to hand hygiene. It's relatively simple. You would use a pair of gloves and you just need some paint. As you see in the top picture, you squirt a little bit of paint onto someone's hand and you have them close their eyes and spend about 15 to 20 seconds washing or cleaning their hands. So going through the motions of what they would do if they had either alcohol-based hand rub or soap and water on their hands. And then in the third picture, you see that they're now looking at where that paint is covering their hands and seeing that they've missed spots on the top of their hands, near their thumb. So it's a great way to visually see what you're doing when you're cleaning your hands and if there are areas that you may be missing. So that as a reminder for the next time you clean your hands, to make sure that you are focusing on those areas so they're not forgotten. The last piece is then removing those gloves and looking at your hands to see if there's any paint underneath of the gloves or if you contaminate yourself, because that can also happen as you're removing gloves in practice. Another exercise is using some type of fluorescent gel or fluorescent powder to perform a similar simulated hand cleaning process, and then using that black light to see where the gel is, and then after washing with soap and water, seeing if you've removed that completely. Another idea that I'll share quickly, because I don't want to take up too much time, is the secret shopper idea. And this I share because some of you may have auditing and feedback programs already established in your facility, but often if it's the infection preventionist or an administrator or nurse manager, sometimes when you are out walking through a unit, people know you're watching them and may be at their absolute best behavior. And so picking someone who is on that unit, could blend in and maybe perform some observations about hand hygiene may be a way for you to get some on-the-ground, real-time observations that you can then use to provide feedback for educational purposes to your staff. I'm going to run through some of these slides a little bit quickly for just so we do have time to get to questions, and because some of this information has discussed, but I will emphasize again that contact precautions is recommended for residents who are colonized or infected with Candida auris. And ultimately what this means is that gowns and gloves should be worn every time you are entering that room. Hand hygiene should be performed before you put those gown and gloves on, and hand hygiene should be performed again before the gown and gloves are removed. It's also important to remember that if there are multiple residents in a room, that each resident's individual space is treated that way, so that gloves and gown are removed and hand hygiene is performed before care is being provided to additional residents. I included these slides in here and a link, so I will let you review these slides, but I did include some information on sequences for putting on or donning PPE, as well as sequences for doffing or safely taking off PPE. And also want to share that it really does take practice to appropriately do this because it is possible to contaminate yourself, especially as you're taking off your PPE. And so walking through this process and having staff observed by a trained observer can help provide them feedback and ensure they're knowledgeable. We've also found that having refresher sessions can be helpful, especially if contact precautions hasn't been used routinely or it hasn't been used recently. So this is one of the most common types of signage that we will see in nursing homes. And unfortunately, it doesn't always communicate the information that is really important for staff and for visitors to know. We often will see that people don't stop at the nursing station, and when they're asked about what the sign means and what it's meant to convey, it's very frequent that people are not aware. So using signage that clearly communicates the type of transmission-based precautions. So for Candida auris, we're talking about contact precautions in addition to standard precautions, and clearly indicates the type of personal protective equipment that is required, and then is displayed immediately outside of the room is most helpful. I wanted to include a couple of examples about setup, and these are some pictures that we have that are from facilities throughout the country, where they have come up with their own ways of making sure that PPE is available at the resident's room. Also important, again, that there are plans for restocking, so when staff go to use the PPE, it's there and it's available. That there's access to alcohol-based hand rub. That there's also access to cleaning supplies, that there's a trash can for discarding PPE, and that ideally there is equipment that is dedicated to the contact precaution rooms and to that resident. And so here is an example where they've clearly marked that this equipment is to be used only for this resident who is in isolation, or in this case in contact precautions. So as was mentioned, ideally residents in contact precautions are placed into private rooms, but we recognize that this is sometimes a challenge. There may not physically be the space to do this. Sometimes there are residents that are male and female and can't be placed into the same rooms, or there may be other limitations that prevent this from happening. And so a couple of other suggestions include cohorting, or placing residents with like multi-drug resistant organisms together, but those beds should be at least 3 feet apart. And again, that resident and their surrounding environment should be treated as separate areas, such that PPE is removed after providing care for a resident and hand hygiene is performed before then moving on to another resident. So a lot of questions have come up specifically asking about the duration of contact precautions. And as has been mentioned, colonization with Candida auris specifically can last for prolonged periods of time, and especially on some of those individuals like we've been talking about who are on ventilators or have other invasive medical devices, and those who require high levels of care. And so right now, the Health Department and CDC, we have been working together to help assess for ongoing transmission in these different facilities. And so contact precautions should be continued at this time. But as has also been mentioned, when individuals improve clinically, it may be possible to consider alternatives. And so further decisions regarding discontinuing contact precautions should be made as we learn more and in consultation with the health department, because we don't recommend routine screening of individuals. And a last quick few points, I've included a link here. As was mentioned, products should be active against C. difficile spores. Those are called List K agents per the EPA, and there's a link here to a list of products that meet those requirements. One consideration is to use this across the entire unit or facility if your facility has been identified as having multiple residents who have screened positive, meaning that they are colonized with Candida auris. High touch areas are areas that should be focused on in the cleaning and disinfection process, and I won't go through all of them, but these are things like handles, bed rails, sometimes call lights or telephones. And in general, it's important to try to establish patterns. So this is going back to the basics, but patterns within rooms that are being cleaned, going from dirty to clean and top to bottom in order to prevent recontamination. And then another important issue is contact time, understanding what that is. So this is the amount of time that is required for a disinfectant to be able to kill pathogens on a particular surface. And so look at your products that you're using, identify what that time is. Sometimes if they're very long, they may not be practical. And I included an example picture here of a facility that in order to help staff know what the contact time is, they clearly labeled in large font their different products. Shared medical equipment is one way that infectious pathogens can be spread from one resident to another. So I know we quickly talked about trying to dedicate equipment to residents who are in contact precautions, but it's also very important to make sure that access to cleaning products is easily available for staff so that they are able to clean products during their normal workflow. And then it's also important to consider who is supposed to be cleaning what. So I've included a picture here of a checklist that we have seen some facilities use where they go through their facility and the different types of rooms and identify the surfaces as well as the shared equipment, furniture, etc. And they go through and list who is responsible for cleaning it. So is it the EVS, the environmental services or housekeeping? Is it nursing or another type of staff? And how often should they be cleaning it? That way they're ensuring that there are not items, or it's much less likely that items will be skipped over. And then one last slide on environmental cleaning, developing auditing and feedback programs similar to hand hygiene or PPE use. These are programs where you can either perform direct observation or consider doing something like placing fluorescent gel markings or a powder marking on different surfaces throughout the facility that can be seen with a black light, as you see in this picture. And then going back after staff should have had the chance to clean those items and looking to see if the marks remain. Sometimes you see that they have been wiped a little bit but aren't completely gone. And sometimes you'll see they're completely gone, or maybe they remain. But that data can be used again for further education to provide feedback to the staff that are performing that cleaning and disinfection so that they can alter what they're doing and make sure they are getting those top priority areas. And then last, I just want to share that Orange County does have a specific infection control transfer form. We have seen that communication at all health care facilities at times of transitions of care can be an area where that communication falls through the cracks. And so this is a form that the county actually already has available that you can use to communicate, in addition to verbal communication at any time that a patient or a resident from your facility is moving from one place to another. And it can also be helpful to keep a running list of residents with an MDRO, just so that within your facility you can understand where they're at and can use that information for movement both within the facility and as a reminder to communicate at times of transfer. And then should they be readmitted, you have a list there that reminds you of their MDRO status. So I think Dr. Valbenini, feel free to comment as well. There's a couple resources that we've included on this slide set, but I think wanted to give you all a chance to ask questions as well.
And you can type your questions by using the chat or Q&A panels, and you can access these panels by hovering your mouse over the bottom center of your monitor screen, where several icons will appear. You can then click either the chat or Q&A icons to open the panels, and then type your questions or comments that will be addressed by the presenters.
Thank you, Lynette. So we do have one question in the queue right now. This was asked early on was this patient on antifungals that developed into this resistance is the question. I think that the question is on the initial first case that was identified. The person wasn't on antifungals, though was on broad-spectrum antibiotics. But as a question of exactly how this resistance developed, seems, particularly given that we have seen multiple persons screen positive in multiple facilities, seems that it wasn't a matter of the organism developing resistance following exposure to antifungals, but more a inadvertent passage of colonization from one patient to another, likely within a skilled nursing or within a healthcare facility setting. So, and I don't know if Stigda or Kara, you have other comments about that method of passage.
Can you all hear me?
Yes.
Yes.
Okay, sorry. Yeah, I think when there's kind of two types of resistance we see, and one is just it's intrinsic to the pathogen, or not intrinsic, but the patient will have it initially, and then we've seen patients, especially the ones the two cases we know of so far that have developed the pan resistance is because of exposure to antifungals, but you don't need to have the exposure to antifungals to end up with a pretty resistant strain, only even if it's not pan resistant, because the auris just tends to be a resistant type of organism.
Great, thank you. So this is Matt. One more question's come in. One question is, will we sharing this presentation via email? So what we're going to go ahead and do is we'll probably post this presentation on a website and here with OCHCA's website, and then we will send out a link to people so that they can access this presentation. And I'd like to thank Kara and Stigda for those great presentations. Are there other questions for them or for me right now? We're about at the hour, but we could take a couple more minutes if there are questions.
Again, you can access the chat and Q&A panels by hovering your mouse on the bottom center of your monitor screen, where several icons will appear. Click either the chat or Q&A icon to open the panel, and then type in your question.
We are at the top of the hour here, and again, so I think maybe we will bring this to a close. Both I very much appreciate, again, Stigda and Kara taking the time to present here. If there are additional questions that people have, again, hopefully you can certainly call us at Orange County Public Health. We're at 714-834-8180, and we will be happy to discuss those questions with you or offline. And otherwise, again, great. Thank you for putting up my contact information, or you can email me at that contact email there that Lynette's put up now. And otherwise, thank you all very much, and we appreciate all the work you do, and we will be in contact with you as this goes forward. Thank you all.
Thank you to the presenters for today's informative presentation. This now concludes our webinar. Have a pleasant afternoon.